So for the next hour or so, we will go through some whole body trauma CT for the multiply injured patient and talk about why we would do it and so on. So we'll begin with a bit of an introduction. We'll talk about the concept of the golden hour and then really sort of focus in on whole body CT, the imaging related to it, what the value is, what are some of the issues related to doing whole body CT, and then I will sort of give you a bit of our approach to it. But the caveat is that there are as many ways to scan a trauma patient as there are level 1 trauma centers. So everybody skins the cat differently, but there are going to be some consistencies in some areas that are sort of pearls that we do. So hopefully I will try to highlight all of that as well. So trauma is the #1 cause of death in people under the age of 46. I'm no longer in that category. It's really weird. But that accounts for more than 200,000 deaths every year in the U.S., and that's on U.S. soil. We're not building in military stuff as well. It is a huge killer. No, I did something. All right. It's the 4th most common cause of death in all ages in U.S. and Western Europe, and it follows heart disease, cancer, and stroke. And as I told the residents this morning, those are diseases that get an awful lot more attention than trauma gets. But because trauma is affecting a younger population, those diseases, it's responsible for more years of productive life lost than cancer and stroke combined. So it is a big, big problem, and it's killing essentially younger patients than cancer and stroke. So we know that there's a trimodal distribution of death. A lot of this data is coming from the world wars and so on, where there are catastrophic deaths within minutes, and within the first hour, there are diagnoses that need to be identified and treated in order to save lives. So golden hour is that small window of time. It's not necessarily 1 hour, but it is a small window of time with which the rapid identification and treatment of these life-threatening injuries has to get made. And according to the ATLS, it is not possible clinically to exclude an abdominal or pelvic organ injury. So your physical exam on that patient is not going to say, this is totally fine, there's no liver laceration here, anything like that. But spiral CT, and when I say spiral, this is going back to single slice helical CT back in like my residency days, okay, has a negative predictive value for abdominal trauma of 99.6%. And that study came out of New Jersey and involved both residents and attendings. So it's a very powerful tool. So all of a sudden, where the physical exam wasn't able to help, we've got an imaging tool that can really answer these questions with an incredible negative predictive value. So really, CT is our workhorse. It's going to help triage our patients. Who's going to get discharged? Who needs to be observed? Who needs to be in the OR? And who's going to benefit from angiography? Okay, and I'm glad to say we've got all of those people here today to cover all of these things. So the goals with ATLS, with someone that's a trauma patient, we're going to begin with triage, which needs to be rapid, needs to be accurate. Over triage can kill, under triage can also kill, but over triage uses all your resources, and the people that you could save no longer have access to those resources. Transportation needs to happen with the patients being brought to the right place. Okay, in Manhattan, if there's a trauma in front of the NYU Medical Center, God forbid they bring that patient into NYU Medical Center. They should bring them 2 blocks down the street to Bellevue if they want that patient to have a good chance of surviving their trauma. Diagnosis needs to be done rapidly, needs to be done accurately, and often in those cases we have a limited clinical exam, and that's really where we come in as imagers and where whole body CT can play a role. One of the biggest things we can do is determine, is there a life-threatening injury? Is there hemorrhage that's going on? And these are big pieces of the puzzle that we need to be able to provide in making these diagnoses. And therefore, that patient can then be brought to the appropriate place. What's the disposition? OR, angio suite, observation, or discharge? And all of that has to happen in that golden hour. So that diagnosis has to happen then so that the treatment can happen then, all within that short window of time. All right, so this is really a value-added procedure that we can add with those areas in green as imagers to help our clinical colleagues figure out what's going on with this patient, what needs to be done, and where does that patient belong. Okay, so let's look at whole body CT and trauma. This is the image that I give to all of the trauma surgery residents when I give them a lecture basically every month when they come on the rotation so that everybody plays nice after hours, that the surgeons know what we do. And this is the idea that when they have a trauma patient, CT is their one-stop diagnostic shop. Okay? Everything that they're worried about that they want to work up, I want to do in one visit to the scanner. I want to do it with one shot of contrast, ideally. Okay? I don't want this back and forth. You don't want them coming back in 2 hours and getting the piece that they didn't get earlier. Ideally, we want to answer all the questions. So when I got to Bellevue, this was taking days to do, and we've reduced that down to 15, 20 minutes or so. Okay? So this is the plan. This is the goal. I would go into the trauma bay when the trauma patients would come in, see what the exam looks like, find out what the history is, make sure I know what the neuro exam is, talk to the surgeons. What are they worried about? What are we going to do? I'm making sure that we answer all of that in one visit. So until we had built out all the protocols, I was there helping with all that stuff. So whole body CT, the general definition is it's some kind of complete imaging from head through pelvis in a single visit. Okay, so doing it basically in one visit to the scanner, ideally one shot of contrast. And that's in contrast to selective CT, where you're just sort of doing certain parts but not others, and you don't have the full spectrum of coverage from head through pelvis. And this may be done for certain clinical reasons, but that's what we're sort of comparing against, where you may do one or two body regions that may be based on the history, the mechanism, the physical exam, maybe what the x-ray had shown in the trauma bay, something like that. But the idea is that whole body CT allows for almost immediate imaging of multiple body parts in a very rapid and efficient way. A couple things to consider. So what are the issues that are going to surround some of this? Patient selection. We can't just obviously do this on everybody that comes in with a broken toe, perhaps. That's not appropriate. So how do we select our patients? How do we do this? As I've told the residents, and I can only imagine, in my own institution, if you put the neuroradiologist, the head and neck radiologist, the abdominal, the chest radiologist, the bone radiologist in the same room and said, figure out how to do this in one visit to the scanner with one shot of contrast, there'd be 4 dead radiologists, and the bone radiologist would be walking out of there going, I really don't care how you do it. So everybody wants their contrast in a different timing, and everybody wants their scans done a certain way. And so there are definitely questions about how you want to go about approaching this. And we're in an institution, I'm in an institution where there is an emergency radiology section, and if you don't have that, then this is getting farmed out to different subspecialists, and so you've got to make everybody happy. So it's not an easy task to do, I will tell you that. This is why I'm great. What are the benefits with whole body CT? So how can we justify doing this? What are the radiation issues surrounding this? And then sort of lastly, if you're scanning so much, you're going to find incidental things. And so that's just a piece to keep in the back of your mind. We're certainly not going to focus on that. But when it comes to patient selection, there's a prospective cohort study that was looking at the accuracy of the decision of the trauma surgeon in deciding who was going to benefit from whole body CT, looking at 660 whole body CT patients versus selective CT scans as decided by the trauma team. They found that they did 15% of the patients with whole body CT. Of those 32% had multiple body regions that were injured, and 6% on selective CT. So, and what they came back is with multi-region injury predictors were GCS less than 9, trauma team getting activated, falls more than 5 meters, and cyclists being struck. But then they still concluded with this, after looking at that and retrospectively applying that data to it, that the surgeons were better at picking it out, because if you applied all of this data, you would have done a lot more CTs, whole body CTs. So the conclusion was, and the quote is, the decision to perform whole body CT should be at the discretion of the treating clinician. Applying a prediction rule would have increased those whole body CT scans without improving the overall accuracy. So our clinical colleagues are usually pretty good in deciding who's really got that potential for being a multiply injured patient that needs better evaluation. And then there's the idea, how are we going to scan these patients? And there really is no consensus on this, and there's sort of 2 big camps of whole body CT. There's the dual pass and there's the single pass. And the dual pass is 2 separate scans with the arms manipulated in between. So it would begin typically with a head face C-spine non-contrast, get the arms up, followed by a chest, abdomen, pelvis enhanced study. So non-con, flip the arms up, get the injector going, and then do a chest, abdomen, pelvis. That's in contrast to the single pass, where there is no arm repositioning, and it begins with an unenhanced head, And then you get basically an enhanced study from the neck down through the pelvis. And that raises a whole pile of questions. So doing all of that without manipulating the arms. So what kind of timing are we doing? Are these arterial phase studies? Do we need to do multiple phases? How are we going to cover it? And what on earth do you do with those arms? Right? You wish you could disarticulate them like a Barbie doll, snap them off, deal with the scan, and then put them back on. And so you're left with all these different choices here. And if this looks familiar, you're a Beatles fan, probably recognize that from the Help album. They already figured out this whole thing ages ago. If you can get the arms up, that is the lowest dose way to evaluate the torso. Still a very adequate way to do a CTA neck because you've got that air gap between the arms and the C-spine and the neck, and it does tend to work. The lowest quality study is what my new hospital in the middle of Long Island has been giving to me, the arms down. Yeah, we're trying to get them up. No, you guys have a success rate of 2%. There's no way. When I have arms down on a trauma CT at Bellevue, it's because there's a fracture in the humeral head or there's a scapulothoracic dissociation, in which case really the arm can go anywhere. But the dose goes up 45% if you leave those arms down. And you're degrading the part of the study you want to see, the liver, the spleen, the kidneys, because you've got both elbows sitting down there at that exact level, and it destroys your ability to make a nice, confident call. So trying to get the arms up is very helpful. A swimmer's view is not bad if that's the best you can do, and usually if one arm is down, that's a good sign for me to look at that shoulder because there's probably a problem with it. We don't do this one where they rest arms on the pillow. That's Harborview has been playing around with that one, and they got not quite as good as even as a swimmer's view with it. So these are the considerations, again, that we're looking at. Patient selection, really at the discretion of the trauma surgeon, and that's what we're still doing. There isn't a really good prediction rule that's been parsed out to really figure out who's going to benefit. But the idea is that you're taking into account the mechanism of injury, the GCS, what the vitals are looking like, injury location, injury patterns. So when you see certain injuries, you're thinking about other things that go along with it. Bad pelvic fracture, head injuries, high energy trauma, you're going to want to deal with these things. In New York, when we get somebody that's a fall onto the subway tracks, we scan everything. Those patients are not normal that fall down. They're intoxicated or otherwise altered in some way. It's a 5-6 foot drop. It's a hard landing. They're not protecting themselves because they're altered invariably, and so they wind up with bad injuries. So things like that are going to play a role in whatever your experience is. If you guys are seeing snowmobile accidents or something like that, and you're going to go, you know what, we've seen too many of these where there's bad stuff, we're putting them all in that category until we learn otherwise. Scan protocols, dual phase, single pass, dual pass, single pass. What are you going to do with those arms? What makes the most sense for you? And part of it is going to ultimately also come down, what are you trying to do with the neck? Are you happy with an unenhanced C-spine CT, or do you have a strong indication to do your neck as a CTA of the neck because you're concerned about a cervical vascular injury? My only comment with that is the guys out of Denver, I think, are very aggressive with this. I don't see anywhere near the kind of numbers that Denver is seeing with their criteria. They have every criteria that if there's, facial fractures and certain C-spine fractures, and if the wind blew on the guy's face in the right way, then his neck is going to be destroyed. And 20% of people don't even have that. We're not that aggressive, and we don't see a lot of problems with it. I'll show you the one problem, but we don't see a lot of problems with that. So I think every institution's got to figure out what your patient population is, what the mechanisms are that you guys are seeing. In New York, nobody drives that fast because it's always busy. I don't have highways, so I don't get good aortic injuries anymore unless it comes from Brooklyn or something. So we do have a skewed population, but we have everybody walking across the street like they own the street, and the taxi cabs think they own the street. So somebody's going to lose, and it's going to be the pedestrian. So we get those instead. So there's a lot of questions that go on with this. So let's look at some of the benefits in terms of, we'll start with survival here. So some studies that have compared the mortality in about 1,500 trauma patients that got whole body CT versus about twice that number that didn't get whole body, that got some sort of selective CT. What did they find? That the whole body CT was associated with a 25% reduction in mortality in this one study published in 2009. Another study, however, compared selective CTs versus CT of the chest, abdomen, pelvis as a routine in high-energy blunt trauma patient, looking at a meta-analysis on these ones, as there was no randomized controlled trial for this, they concluded that while diagnostic value of whole-body CT seems clear, the benefits on mortality couldn't be established in their review, in their meta-analysis. The REACT-2 trial that came out of Europe was published in 2016. It was the first randomized trial on the immediate whole-body CT versus selective CT. So it was an international study, multi-center, all academic level 1 trauma centers, all using 64-slice CT technology or better. Adult patients over the age of 18 with altered vitals and potential for life-threatening injuries. Okay? 540 roughly in each camp of whole-body CT and selective CT, and so what did they find? No significant difference in mortality, increased dose of radiation for the whole-body CT group, hold on, faster time to diagnosis, but there's a major issue with this paper. There was no consensus for the selection of who was going to get a whole-body CT or not, and the problem is that almost half of the patients that were selective CT patients ultimately got all regions scanned and basically became a whole-body CT. So they degraded their own study tremendously by basically merging or blurring the differences between these patients tremendously. But it also means that you've got a lot of surgeons out there that ultimately felt uncomfortable not having everything done and ultimately felt that they needed to fill in the gaps that they didn't scan initially. So the conclusions, I don't think, are quite as robust as they otherwise would be. They described that 36% of whole-body CT patients had an ISS, though less than 16, which is also less than other retrospective papers. Now, I'll talk for a second about the injury severity score so you know what it is. There's an abbreviated injury scale where there's a score for each body region 1 through 5, and you plug these numbers into a calculator, basically, where you add up the squares of the 3 highest numbers to get your injury severity score. Okay, so this patient over here has got a 1 for a head, a 2 for a chest, and a 3 and a 4, and you would take the top 3 numbers and square them. Okay, so square the 2, the 3, the 4, add them up, we get a 29, and major trauma would represent a number that's greater than 15. But this is a retrospective calculation, not a prospective calculation, because the only way you're going to know what to fill in those numbers is having all those imaging studies. So the error also, if you make a mistake in your abbreviated injury scale, filling in your numbers on this calculator, it gets magnified squared, okay? And if you do more imaging, you're going to cover more territory, and you might find another rib fracture or something else like that, therefore that you can add it to those things, and then that gets squared, and so your injury severity score goes up from there. So that's part of it, but the fact that it's also a retrospective number means you're not using it for triage as to who can get a whole-body CT or not, because it's a retrospective number after all the injuries have been discovered and calculated. Okay. In terms of time saved, studies looking at over 2,000 whole-body CTs versus 3,700 selective CTs. Whole-body CT saved an average of 32 minutes of time in the ER. And another study showed that 54% time decrease in the ER and 25% less time in the CT scanner by having sort of a uniform protocol. Everybody kind of knows coming in what we're going to do, how we're going to do it. We don't have to keep changing parameters around. And so they've been able to move patients through the ER and through the CT scanner more quickly, more efficiently. Other advantages, routine CT of the chest, ab, and pelvis and trauma patients with closed head injuries that are therefore unreliable examinations. So it's veterinary medicine. What happens when you do routine torso scanning in those patients? Unexpected diagnoses in 38%, with management changes in over 25% of those patients. So CT is adding value when clinical exam is, the ability is certainly diminished because of other head injuries. And those are head injured patients, and we're scanning the torso. And the only thing we know about them for sure is that they're head injuries. Another study prospectively looking at whole body CT in 1,000 multi-trauma patients, over half without obvious external signs of injury. Whole body CT found over a third of abnormalities in the head, 5% C-spine injuries, 20% chest, and 7% abdominal injuries. So there are things in there that are injuries and change in management in 1 in 5 of those patients based on doing the whole body CT. So lots of potential for value added in these cases. But let's come back and let's look sort of at radiation. So we've got the REACT trial that showed actually an increased dose. How strong a paper that is, where you've got half of your selective CT patients basically becoming whole body CT, sort of puts that in question. We've got another one that found that while the whole body CT dose was greater than selective, the dose per admission did not change, meaning that over the course of that patient's hospitalization, they probably were getting all the other scans to fill it all in. So initially up front, yeah, the whole body is more, but per admission, they're coming out as a wash, okay? Another one showed 25% reduction by doing whole body CT versus segmented whole body CT. So if somebody's actually getting all the parts done and they're getting them done separately, there's a lot of areas of overlap. So you can actually knock the radiation dose down if you look at it from that perspective. Overall, it's probably something of a wash in between, or if not, perhaps saving a little bit. There is a study, the DO-RE-MI, which is the dose reduction in whole body CT for multiply injured patients, study that is a prospective study that's supposed to be going on, looking at 500 whole body CTs with regular scan parameters and 500 whole body CTs, trying some new lower dose stuff, and it is still not out with the final paper yet. So that's something that's in progress. We don't know what they're going to find there. So basically, a lot of the take home on this with whole body CT, and this is a slide that I've inserted from another talk that, you know, some people know this as total body CTs, pan scans. If you've been at Maryland, they're Shan scans because Shan made the protocol. And you guys know Savas Nicolau, who was here in Vancouver. They got a really cool name. They call it the RIPIT, the Rapid Imaging Protocol in Trauma. I spread that around the globe because I think it's a really cool name. So I put it up in here. So basically, in my mind, a lot of the take-home advantages are really patients with stable vital signs, we can definitely make an impact on increased survival. There's also papers out there that show increased survival in patients with unstable vital signs. And the question to ask is, why on earth are we putting unstable patients in the scanner? There are a couple places in the globe, and one is in Amsterdam, and I think one is in Japan, where there are CT scanners in the trauma resuscitation bay. Okay, and it is on a sliding gantry, and so it can dock with resuscitation table 1 or 2. And so you take the gantry and you can slide it over to the table. So these patients don't have to be moved. They are being resuscitated on a CT dockable table and getting scanned. And so some of these unstable patients, they would whisk through the scanner, find injuries that would allow them to intervene and increase survival. Head injured patients that can't tell you what's going on, what hurts, what's happening, increase survival by doing whole body CT. Change in management has been shown by doing whole body CT, decreased time in the scanners, we said, decreased time in the ER, and probably overall equivalent radiation. So there's a lot of good reasons that this makes a lot of sense for the right situation, okay? So, you know, when you're traveling down that highway, figuring out what to do, you got to make a decision. Are you going to go the segment way, or are you going to go the pan-scan express way? These are all different thoughts that are out there. I'm going to break down sort of each region and sort of talk about how we approach some of these things. So we'll begin with the head, performed obviously unenhanced. You want a dry CT head initially. We do it now with a spiral technique. We've been doing it spiral probably for about 5 years or so, maybe even longer now. It is definitely faster. Your patients that are wiggly have less opportunity to wiggle if you can do it fast. We have MPRs readily available because your scanning is a volume. So these vertex epidural hematomas are no longer questions. You can be definitive because you've got access immediately to images that can look at it. We include the face and the C-spine, and we do this all now in one pass. So the old way of tilting the gantry and bringing it back and then scanning a C-spine and scanning a face, all of that took about 2 minutes to do. We've traded that years ago now for a less than 5-second acquisition spirally. Top of the head, bottom of the C-spine, face is collateral damage, so we always have the face, whether they've asked for it or not. So we have all of the data there. And this was the big reason why we had started it. So this was the case. Before we had 24/7 radiology, coming in the morning at 7 a.m., the overnight resident's reading this head CT, and he goes, "Do you think that's blood in the brain, or do you think that's partial voluming?" And I said, "Well, you got a big bump up there. It certainly looks suspicious." I said, "Let's look at the bone windows, and nice crack there across the across the skull." So I'm going, "Yeah, I think we're dealing with an epidural hematoma." And he goes, "Well, it's probably pretty small." So we took the CT data that was axially done, we uncoupled it, we made sagittals, we made coronals on it, and I convinced the resident that yes, this was a good vertex epidural hematoma. Having that immediately available for problem solving is great. Fractures that may be in the plane of the scan, now are no longer an issue. You can whip up a 3D and spin the head around and clarify and look at some of those. This is one of the biggest controversial areas is what to do with the neck. So you can do a neck CTA as part of your whole body CT. So if you're doing the single pass, you're typically doing your neck as a CTA. If you're doing a dual pass, you're probably doing your neck as a cervical spine that's dry. Okay? So the idea of doing a CTA neck, the goal is to screen for blunt cervical vascular injuries, in addition to your C-spine integrity as well. So there's no extra radiation, you're already scanning it, there's no extra contrast load, it's the same load, dye load that you're using. The incidence is reported in up to a little over 3% of blunt trauma patients. I don't think we're seeing quite numbers like that are that high. Again, with the clinical prediction rules, they exist, but then there's a big chunk of patients that have none of the screening criteria that they maintain are positive. And we know that early diagnosis and treatment can reduce the morbidity from post-traumatic ischemic stroke. And here's the one case from our institution that has the initial CT and 2 days later, the infarct related to the injury. This is an incredibly rare event for us, but we are not aggressive where I am with CTA necks. And I think it may just be that we're not getting high-speed trauma, and maybe that's part of it, but our patient population is not matching what is coming out of Denver. But I don't know. It's going to be different depending on your catchment area, and you guys have a highway, so it may be different. Then it comes to the torso, the chest, abdomen, pelvis, and what's the timing for the contrast. I'll first say that there is no role for pre-contrast imaging. I'm not concerned with you guys, but there are some other bigger meetings, we have some international places, and I've had people come up and ask me, "So do you do the non-con first on the traumas?" And I'm like, "Whoa, no." But I've put it in there just in case there's anyone out there, so they don't have to feel they have to ask it or whatever. It's out there. No. There is a huge diversity in how, again, people want to do these scans. Okay, so I'm not here to say that there's one way that is best by any means. Typically, there's a fixed scan delay. It's usually easiest that way to say we're going to start at this timing. It just makes it easier. So let's break down each part. So with the chest, are you going to do it as a routine enhanced chest with contrast, or are you going to do it as a CTA of the chest? And let me go back in the literature and explain that this does not need to be a CTA. Okay? Traumatic aortic injuries readily diagnosed on anywhere from arterial through venous phase imaging. Back in 1998, coming out of Maryland shock trauma with single slice CT, not done as a CTA. How good is CT looking at aortic injuries? 100% sensitivity. Specificity, 99.7%. Positive predictive value, 89. Negative predictive value, 100. Accuracy, 99.7. It's a very good tool. It's a very big vessel. If there's an injury there and you have contrast in that aorta, you're invariably going to see it. So I am personally less concerned about the exact timing of my chest in order to preserve and make sure I've got the right timing in the abdomen. And again, I will show you what our protocols are, but we're not doing the chest as a pure CTA. We're doing a late arterial, early venous phase timing. When it comes to the abdomen pelvis, or really almost anywhere, but the abdomen pelvis is really sort of the highlight for this, it is critical to diagnose and detect bleeding. We want to try to do it at 2 different points in time to be able to be sure that what we're looking at is an active arterial bleed versus a pseudoaneurysm, or if we're talking in the pelvis, or separating arterial from venous bleeding so that the appropriate management can happen. So your options can include arterial for vascular injury, venous for parenchymal injuries. or as we sort of do, we do a late arterial, early venous to really sort of capture both. And then we also selectively will do excrutory phase images around 4 minutes post-injection to look for collecting system injuries. But that also serves as our delay. So it's 2 passes, it's 2 scans potentially, rather than potentially 3 by completely separating arterial and venous. So that's how we sort of got to where we're going with that. If you were to look at who benefits from a delayed phase scan, of all comers of trauma patients, probably about 15% would benefit from it. So the very busy trauma centers do it on everyone. The more tame trauma centers, my place, where you have time to supervise some of these exams in real time, make a decision, is there a benefit to adding this delayed phase or not? And so we give them the thumbs up or the thumbs down on it in real time and let them know whether we need this or not. Okay. Spoke to the residents earlier about pelvic CTAs. These are patients that we are prospectively going to decide whether we're going to add a pelvic CTA to the mix based on the trauma pelvic x-ray. Okay? So almost everybody's getting the chest x-ray. We are selectively doing the pelvic radiograph based on mechanism, based on physical exam, based on pain, whatever. But it's not routine, but it is selected. If we see a pelvic ring fracture, we are probably going to wind up doing a CTA of the pelvis. The CTA is important because you do want to completely separate your arterial bleeds from your venous bleeds, because your arterial bleeds need to be controlled either with angioembolization or pre-pelvic packing if that's what your surgeons like to do. You can use Reboa if people are doing that these days here. But it's important to really separate those injuries because 40% of multi-trauma patients that do have pelvic fractures are going to have a very major bleed going on. Mortality is tremendous. It begins at around 15% and can go up very, very quickly with an unstable pelvic injury up to 70%. So it's a big problem. So about 15% of them are bleeding arterially. The majority, thankfully, will be venous bleeding. But the management, I said, is different. So the arterial bleed needs intervention. The venous bleed needs stabilization. They can put on an X-fix. They can go do the definitive reduction. But if they are arterially bleeding, it needs to be controlled some way or another. Okay? With that, I will move to just give you a highlight of sort of what it is that we do at NYU in Bellevue. Bellevue is part of NYU in terms of the staff coverage. Bellevue itself is a state hospital in New York, and it is a public hospital. NYU's been under contract for a century to staff Bellevue Hospital. NYU has recently expanded and has taken over a level 1 trauma center in Brooklyn and also one in Long Island, and all of their traumas get farmed in my direction with our protocols. So it was interesting doing all this on site and then dealing with some of these remotely as well. Very interesting. We have 4 flavors of whole body CT. The usual, it was named by our trauma surgeons because it's what we usually do. It's well over 90% are the usual. And that is a dual pass scan, as are the northern and the southern CTA. These are names that I made up that are versions of, if you really want the neck, we will do that CTA. That's the upper part of the body, that's northern. You want the pelvis or lower extremities, that's the south part of the body, that's southern. My background is genetics, so the northern blot, the southern blot, all that stuff. So I found an outlet for it. And then if you really wanted a CTA of the neck and the pelvis and you really couldn't decide and you wish you could have everything, yes, there's the global, which is just the pure CTA the whole way. So I'll just sort of run you through what we do here at our institution. So the usual is the dual pass, the unenhanced head face C-spine acquired in about 5 seconds. Arms go up. We give 110 cc's of the denser contrast that we have, which happens to be Omni 350, but I like something a little bit denser. 48 seconds is our timing that we've been doing now for a decade. So we're late arterial, early venous phase, and so what that's getting us is what's critical is in the abdomen, we have parenchyma of the liver, the spleen, the kidneys nicely enhanced, but we still have some residual arterial flow going on. So small pseudoaneurysms and things we're still able to identify. We've it's been I didn't think it was actually going to be this successful. I thought ultimately we were going to break down and have to do pure arterial and pure venous, but this has really worked out very, very well for us. Of course, we can reconstruct the T&L spine from this. What I like about this is I get a one-piece T&L spine stretch out of it without breaking up the chest and the abdomen, and I'm eliminating the overlap of the chest and the abdomen, doing it in one piece. So it's nicer to have a single volume to basically read through. And we do volume reading is the way it's been sort of described, where the acquisition, the thins are basically pushed over to a slave workstation that's directly connected to the scanner in our reading room. And so we have the whole volume on there on a workstation, and we can fly through it and build out our own sagittals and coronals and thicken them up as we need to answer everything. But while the patient's typically on the table, we're reviewing these images in real time. The coronals and sagittals are getting made. I don't really use the coronals. I'll flip through the transaxials, and then I look at the sagittals. I'll screen the spine, screen the sternum, so that the idea is when they're leaving the room, they probably have 90% of what's going on with the patient, save for the undisplaced rib fractures or something small. Okay. So for the person that you want to do a CTA of the neck because they were trying to hang themselves, or they've got a seatbelt mark at the neck, or they've probably got a skull base fracture because there's blood coming out of the ear. These are patients we're going to, instead of waiting 48 seconds, we're going to capture some of that contrast flowing arterially in the neck and through the chest. So we'll begin with an unenhanced head, and then I do a pure arterial phase from the circle of Willis, and I take it to the top diaphragm. The idea is that I want the full carotid, I want the full vert from the arch to the circle of Willis, and if I'm already halfway through the chest, I'll take it to the top diaphragm. Wait a little bit till about 55 seconds, and then pick up again late arterial, early venous phase in the abdomen pelvis. So we do that to try to eliminate, again, some of the overlap that can happen with there. We bolus track this. We pick a spot in the neck. We scan there during the delivery of contrast. When we visually just see the carotid light up, we kick the machine into go. And so that's how we time that one. This was the first guy I ever did this scan on with the Northern. I had the scanner for a little bit. We started playing around with it. I'd sort of built out the protocol. This is a guy changing a light bulb in one of the courthouses in downtown New York before I guess they went LED. And it's a two-story open lobby kind of thing. He's up on some sort of scaffolding and he's trying to change it, and he falls off of it and his face slams into some other AC unit or something sticking out of the wall. And it's a horrible looking head CT. He's got a lot of edema in his head. He's got a hematoma in his brain over here. He's got blood in the ventricles. He's got a depressed skull fracture fragment. He's got blood in his sphenoid sinus and his maxillary sinuses, and it looks terrible. And just that morning, I'd given the trauma team my lecture like this. I said, I've come up, I think this is a protocol that we can try. And they're like, this guy, let's do it. So here's the CTA. Couple interesting things going on with this guy. First of all, he's actively bleeding, arterial bleeding in his brain. I've only seen this one other time since, in 16 years. So actively gushing blood in his head, and that blood is actually going into the sphenoid sinus through the fractured walls of the sphenoid sinus, and it was actually coming down through the floor of the sphenoid sinus, so it was broken, and coming out the suction. So the suction blood was actually arterial blood that was supposed to be perfusing his brain. The other thing I'm sure you can see from the back of the room is that there's no flow to the entire left cerebral hemisphere, okay? This is a horrible, lethal injury and stopped any potential heroics of neurosurgery trying to do something. There is nothing that anybody's going to be able to do for this guy. So complete left-sided stroke, active intracranial hemorrhage, diagnosed and figured out by adding that CTA up through here in the skull base. So the next one is what we would do sort of for your pelvic trauma patient. And so we can isolate it to the pelvis, or we can take it longer as need be, but predominantly this is designed for the pelvis. So while we're waiting our 48 seconds in the usual, we're going to capture the pelvis in a pure arterial phase. So we begin with the unenhanced head face C-spine, we get the arms up, and we're typically going to, for this, do a fixed delay around 25 seconds to get in the pelvis, unless it's a much older patient that we think is a vasculopath, and then we'll maybe bump it up to 28 seconds or something. And then chase that contrast back up at the top of the chest and do our 48-second chest, abdomen, pelvis. So the idea with that is that we can get a pure arterial phase of the pelvis so we can identify and separate the arterial bleeds from the venous bleeds instead of having them potentially mixed. Because you want to be definitive about it, and there's no point going to angio with a pure venous bleed. That is something that the surgeons can deal with. Otherwise, to just fix the pelvis. Okay, and then here's the delayed phase where we see that the contrast is expanding inside a hematoma and active arterial bleed in the pelvis, and making sure we know what's venous and what's not venous. And then lastly, this is going to be what, again, some of the busier trauma centers are doing that aren't able to really start picking and choosing, and they're running basically in like a mass casualty mode all the time because they're just that busy. This is your unenhanced head followed by your pure CTA. Circle of Willis, straight down to the pelvis. Great for arterial stuff, terrible for your parenchymal evaluation of the abdominal organs, so you need a pure portal venous phase then at that time to go with it. And then the question is, if there's a collecting system injury or a potential collecting system injury, you need another phase. You need an excrutory phase on top of it. So that's sort of the way the menu sort of works. This is, these are them all sort of lined up, compared against one another, with the red stuff being our CTAs and the purples being our late arterial, early venous, and then the blue over on the last one being a pure venous phase. So again, our aim is to get into the belly, late arterial, early venous. That's the way we've been skinning the cat, and I know lots of people that do a lot of different ways of doing it. And some people will do and like their CTAs of the chest, but they may run that CTA chest down into the upper abdomen to get an arterial phase, liver, spleen, kidney, and then do a pure portal venous phase and so pass the liver, spleen, kidney twice. In order to get the two phases and sort of reduce radiation a little bit that way, minimize the overlap, but get the whole upper abdomen in two complete phases. So it's another way definitely to do these things. And again, after we scan the abdomen pelvis, we're looking at those in real time, determining who's going to benefit from having a delayed phase scan, because what we don't want to tell our surgeons is we see something in the liver and it's either a grade 3 laceration with an active bleed or that's a hemangioma. Because Dr. Perry doesn't want you to give him that differential and walk away and say, have a great night. Because he's not going to have a great night. He's going to pull his hair out of his head going, I don't know what to do with this person. Ultimately, it's going to be dropped right back in your lap, on the table, figure it out, right? And you don't have to deliver contrast again if you do a delayed phase and watch this either fill in as a hemangioma or wash out if it's a pseudoaneurysm, or continue to puddle if it's an active bleed. So there's ways of figuring all of that stuff out. How am I doing on time? All right. With penetrating trauma to the torso being sort of defined as nipple line down through the pelvis, anything that impales that territory, we are doing triple contrast CT. I know this is also somewhat controversial. There are some surgeons that don't care for it. We do like it. We do use it a fair bit. And so in addition to the IV contrast, they're also getting oral contrast, but its job is to distend the stomach. It's not there to go down to the right lower quadrant or anything else.
So it's a few hundred cc's just for a minute?
Yeah. Going between the trauma bay and going into the CT scanner, they get what they get. It's just something to distend the stomach, and that's the only purpose of it. We'll also deliver rectal contrast as well. And it's important as the radiologist to know if you're dealing with a penetrating trauma patient, because if you see free air or free fluid, the only thing it means in a penetrating trauma case is that you have peritoneal violation. It doesn't mean in a blunt trauma case, the same thing where you see free air, free fluid, you're going to be thinking of bowel injury or some other visceral injury that's going on. The only thing you can say is that there is peritoneal violation when it's a penetrating case. So it's good for you to know when you're reading it what is the, is it blunt or is it penetrating. We've encouraged our guys to put nipple markers as wound markers because we found no other use for nipple markers. We have these rolls of them. Nobody uses them. I took them out of the radiology department. I put them in the trauma bay, and I said, I don't like paper clips. They're too big, and they create too much streak. I have a new use for nipple markers. They're now wound markers. So here's an example of one. Here's a trauma bay chest x-ray, anterior stab wound, and that's our little guy down there. Okay, so that's our nipple marker down there on the wound, not on the nipple, although it's probably close. Here's the scout view on the CT chest. Look where that moved, okay? It moved, the diaphragm moved, it didn't, the nipple marker didn't move. But it's a good reminder that when you're dealing with these penetrating injuries to the torso, scan both the chest and the abdomen, because you don't know where that diaphragm was at the time of injury. So you don't know if that knife actually went into the chest or that knife went into the left upper quadrant. Make sure you get both when you get things like that, because where that position of that diaphragm was when that patient was involved in that injury is variable. This is a picture from the triple contrast CT. You can see that we've flooded the colon over here. This was a gunshot wound, and we can see the leak coming out of the colon. Most of the colonic injuries, they look just like this. They're not even remotely subtle. You usually see the defect, and you get a lot of contrast that spills out. We can see the bullet tore apart the kidney, and I called that an aortic injury. Apparently a bullet tore off a piece of the vertebral body, and that was bleeding, and the aorta was fine. Go figure. I'm still calling that an aortic injury prospectively. Yeah?
How much GI contrast do you use for the colon?
How much contrast for the colon is typically about 800 cc's. We mix up a liter. If we can get 800 in without the patient getting too antsy or uncomfortable, we're happy. We have been, it's amazing how often it gets around to that right colon. It's amazing. We just put them left lateral decubitus, we run it in under gravity, and that bag drains, we flip them back over, we scan, and we've got tremendous opacification. It really works out very nicely. And the whole idea behind this is what I showed the residents earlier. It's imagine your colon, your bladder, your stomach. It's like a deflated balloon. And if someone gives you this and says, I think there's a pinprick in there, can you find it? And it's a deflated balloon, you're going to have a fun time trying to look for it. But if you can distend that with fluid, adequately distend it and see something coming out, boom, there's your hole. And that's exactly what we're doing with the stomach. That's what we're doing with the colon. And it's the same idea that we would be doing with the bladder as well, with the CT cysto. This was like, I think, one of the more recent times. The teams had just changed over. They had some resident that was nervous as stink trying to put in the rectal tube. And so this guy comes in. This is our penetrating trauma case. You can see the stab wound up in here. And actually, sorry, I do have the arrow on it. So it's a very recent case I just added in here. And the rectal contrast didn't go up the rectum because the rectal tube is sitting in his butt cheeks. There we go. Okay? There's no penetration for this penetrating trauma patient of the rectal tube. So this is a major triple contrast fail. So we brought him back, and that little bit of stranding led to a giant leak here coming out of the colon. Okay, actually, let me go back and just sort of highlight again. Look how subtle the injury is next to the colon. Okay, there's a little bit of stranding, it comes up to the colon. All right, and that's why when we finally said we need to redo this, there's the extrav, and we can see it and make the diagnosis with that. And here it is on the coronals. So really, this wound up being intraperitoneal as it nailed sort of the anterior aspect of the colon over here and spilled intraperitoneally, which is a little bit different. Looking for collecting system leaks, so renal, ureteral. Around 4 minutes, those kidneys are excreting. I know with a dedicated CT urogram, the typical timing people like is like 8 minutes, 10 minutes or whatever. We typically go between 4 and 5 minutes. We typically go around 4 minutes if we're fast enough on the thing, and I've never beat the contrast out of the collecting system at 4 minutes. Usually it's gross, contrast extrav, and very obvious with that. So we can see there's some fluid around the kidney, there's lacerations, you do the delay excretory phase, you can make the diagnosis. This can be treated non-operatively with a double pigtail ureteral stent, bypass, you divert the urine through the stent, and let the urothelium heal. You miss this diagnosis, 50% are going to come back with an infected urinoma and wind up with a nephrectomy. So it's a very powerful little thing that you can add on and save someone's kidney potentially. Okay, and this was just one other sort of fun case. It was a guy who was actually playing hockey, this is in the US, and got checked. He's got a renal injury, so we got the initial scan. There's the 5-minute delayed excretory scan in axial and coronal images here. But he's got like a congenital UPJ, right? His collecting system is dilated. He's got clot in his collecting system already. He's got fluid around it. And so my excretory phase, I was very unsatisfied. And that's because his collecting system is bigger than most. And I haven't distended this and filled this with contrast to really evaluate it the same way I would with a stomach, with a colon, with a bladder. So by the time they brought him back to me, remember, those kidneys are still peeing contrast, and they'll be peeing contrast for over an hour. When I said, bring him back, I want to take another look, it took them 5 hours to get him back to me. Got him back, flipped him prone just because I wanted to really just look at the anterior side of it, and scanned it again. No more contrast given, just where is the contrast he was excreting. We can see a nice leak coming out of the collecting system here. Very quickly with bladder contrast extrav, most of these patients are pelvic fracture patients. You do need a retrograde study to evaluate the bladder rather than antegrade. Here's an antegrade study because there was no Foley, I guess, in the patient. Someone decided to do it from the top end, and I said, this is not cool. We've not excluded anything. They got the Foley in. We did it retrograde. Boom, nice whole extraperitoneal bladder rupture. That's what it needs. You need to distend that bladder properly. You need a volume about a can of Coke. 355 cc's, 350 to 400 cc's is perfect. Okay, that's the intact bladder, and here we have the extraperitoneal bladder rupture and intraperitoneal bladder rupture. The intraperitoneal bladder rupture, usually a consequence of a distended bladder, the time of a blunt impact, tear into the dome of the bladder, and it just blows up into the intracranial space. So this is our full menu of everything. It's really the usual, the northern, the southern. If there's penetrating trauma, we turn it into a triple contrast study. We can reconstruct the spines out of there as we typically will do, and so that's the way we deal with these things. So in conclusion, think about the role of whole body CT for what works for your guys' patient population. Think about delayed phase scanning to characterize vascular injuries, collecting system injuries as appropriate. And just remember, it's critical to detect bleeding. And if you've witnessed any of the American College publications in the last year, this Stop the Bleed campaign has been huge, not just for physicians, but for the lay people out there. And maybe it's becoming an American thing now. You know, if you're even at the scene kind of thing and you see somebody bleeding out, they want you to try to put pressure on it, take off your belt, make a tourniquet, all that stuff, trying to get the message out there. It's the same thing on CT, basically. We've really got to make sure that these are injuries that we can identify and diagnose for them. And with that, remember, you're trying to do it all while the clock is ticking in the golden hour. And with that, I thank you guys for your attention.